imagine going to the doctor for severe deep pelvic pain.
Right, which is awful on its own.
Exactly. And instead of ordering an ultrasound or, I don't know, a CT scan, they ask to look at the skin in your armpits.
Yeah, which sounds completely absurd.
Right. You'd probably think you were in the wrong clinic, or that they totally ignored why you were there.
Oh, absolutely. But, I mean, it completely upends how we normally think about medicine. We're so used to looking at the body as, like, a collection of totally separate systems.
Yeah, like the skin doctor stays in their lane and the gynecologist stays in theirs.
Exactly. But the body doesn't actually operate with those neat little boundaries.
Which is exactly why this topic is so crucial. Because whether you are a medical professional trying to solve a diagnostic mystery, or maybe someone dealing with unexplained pelvic pain yourself, or just, an insanely curious learner, this deep dive is going to completely change how you view things.
It really is. It changes how you see the connection between the surface of our skin and the hidden musculature right beneath it.
So our mission today is to explore a highly specific, totally fascinating, and honestly deeply impactful medical question.
And it's a big one.
It is. We are asking, can chronic low-grade hidradenitis suppurativa, or HS, in the perineal folds cause indirect, deep muscular bracing and painful sex?
And to answer that, we're pulling from a pretty diverse stack of sources for you today.
Yeah, we really dug in.
We did. We've got clinical guidelines from the NHS, diagnostic criteria from the Centers for Vulvovaginal Disorders, alongside some incredibly revealing psychiatric and dermatological journals.
Okay, let's unpack this. Because before we can even begin to understand how the deep pelvic muscles react, we really first need to understand the threat that is happening right on the surface.
Right, the root of the problem.
Yeah. We need to talk about hidradenitis suppurativa. What exactly are we dealing with here?
So hidradenitis suppurativa, which actually used to be called acne inversa in a lot of the older medical literature, is a chronic autoinflammatory skin disease.
Autoinflammatory, meaning the body is kind of doing it to itself.
Exactly. And before we go any further, the sources are just incredibly adamant about clearing up a major historical misconception here.
Oh yeah, the hygiene myth.
Right. This condition is absolutely not caused by poor hygiene, and it is not some contagious infection you catch from someone else.
That feels like a really important distinction to make right up front.
It's vital because there's so much stigma, but basically, it is a fundamental biological malfunction of the hair follicles in very, very specific areas of the body.
And I read in the sources that it's not exactly a rare anomaly either, right?
Not at all. I mean, it affects roughly 1 to 4% of the global population.
Wow, that's actually a lot of people.
Yeah, millions. And it's about 3 times more common in women than men. It also typically rears its head when patients are, in their late teens or early 20s.
Okay, but I want to dig into that malfunction you mentioned, because I think when people hear, like, blocked hair follicle, they immediately picture a regular pimple. Or maybe just a stubborn ingrown hair.
Yeah, that's what most people assume. But the clinical reality is just light years away from a typical pimple.
How so? Like, what's actually happening under the skin?
So the pathogenesis, the way the disease physically develops, it starts with something called follicular occlusion.
Okay, occlusion meaning blockage.
Right. Basically, the opening of a hair follicle becomes totally blocked with keratin, which is just a normal protein in the skin, along with, everyday cellular debris.
Like dead skin cells and stuff.
Exactly. But this doesn't just happen anywhere. It happens specifically in apocrine sweat gland-bearing areas.
Wait, pause right there. Apocrine sweat gland-bearing areas. What does that actually mean for the average person listening?
Good question. So we have a few different types of sweat glands. Apocrine glands are the ones that are usually connected to hair follicles in areas like the armpits and the groin.
Okay, so the areas with coarser hair.
Right, and they produce a thicker kind of sweat that bacteria just love to break down. So in HS, that specific type of follicle gets plugged up.
So it's like a cork in a bottle.
Yeah, and the duct below the plug starts to expand as pressure builds. It's trapping keratin, shed hair, sebum, and normal skin bacteria all in one spot.
Oh, wow. That sounds like a recipe for disaster.
It is. Eventually, that follicle literally ruptures beneath the skin, spilling all of that debris directly into the deeper surrounding tissue.
It honestly sounds like a city's underground plumbing system getting blocked. Like the pressure just keeps building up, and eventually the pipes burst into the streets.
That's exactly it.
And then it causes continuous sinkholes and massive structural damage to the roads above.
That analogy hits the nail right on the head. And when those biological pipes burst, the body's immune system detects all that spilled keratin and bacteria as foreign invaders.
Even though it's the body's own stuff.
Right. but is in the wrong place. So the immune system launches a massive, localized attack to neutralize the threat. What's fascinating here is that the immune system essentially overreacts to its own debris.
So it brings out the big guns for a routine cleanup.
Exactly. It doesn't just clean up the spill and go back to baseline. It sets off a chronic foreign body type granulomatous inflammation.
Let me stop you again because granulomatous inflammation is a pretty heavy piece of medical jargon.
Fair enough.
Are we talking about the body building a literal wall around the spill?
That's a really perfect way to visualize it. Instead of just sending white blood cells to sort of eat the debris and move on, the immune system walls off the area, forming these incredibly dense, fleshy nodules.
So it's like quarantining the area.
Exactly. The body is treating its own spilled hair and skin cells as if they were like shards of glass or shrapnel.
Oh, wow. That sounds excruciating.
It is, and this is what drives the continuous, agonizing inflammation.
Which perfectly explains the visible symptoms the sources describe. Because patients develop these incredibly painful boil-like nodules and deep abscesses.
Yeah, they get very swollen and inflamed.
And there's a hallmark sign dermatologists look for too, right? Something called a double-headed pseudocomedone.
Yes. That's essentially multiple blackheads that are all sharing a single, heavily damaged follicle opening.
That just sounds so painful. And this doesn't just heal and go away, does it?
No, unfortunately. Over time, the damage compounds. As that intense inflammation persists, those deep abscesses try to heal only to rupture again.
A vicious cycle.
Exactly. And the body ends up carving out these interconnecting tunnels under the skin, which are known clinically as sinus tracts.
Tunnels under the skin. That is wild.
It's severe architectural damage. And as the body desperately tries to heal this constant churning damage, it lays down thick, rope-like hypertrophic scarring.
So the skin is basically getting paved over with tough scar tissue.
Right. The structure of the skin is just fundamentally altered.
See, if this plumbing disaster was happening on, like, your forearm or your shoulder, you just end up with a very painful, very prominent scar.
True, which is bad enough.
But because of where these specific apocrine glands actually live, the structural collapse causes a completely different cascading mechanical crisis.
Yes. Location really is the next crucial piece of the puzzle here.
Yeah, geography seems to dictate everything with HS.
Yeah.
The disease specifically targets intertriginous areas.
Right, which are those regions of the body where skin naturally folds and rubs against other skin.
So we're talking about the axilla, which are the armpits, the groin, the inner thighs, the buttocks, and the folds under the breasts.
Exactly, high friction zones.
But for the specific focus of this deep dive, we are zooming in on the perineal, and vulvar skin, basically the area right around the pelvic floor.
And the environment in those specific areas is basically a pressure cooker for this disease.
Because it's trapped and constantly moving.
Right. They are subject to constant mechanical stress. Just the daily friction from walking or sitting down or even wearing tight clothing physically exacerbates the condition.
That makes sense. You can't just stop walking to let it heal.
Exactly. The skin is occluded, it's constantly warm, and it's experiencing microtrauma from all that friction. And when you add in the severe scarring we just outlined, the consequences for mobility are just drastic.
I can imagine. Scar tissue isn't very flexible.
Not at all. Those thick bridging scars can become so rigid that they literally tether the skin down. They totally destroy normal tissue elasticity.
Okay, I want to challenge this for a second, just playing devil's advocate here.
Sure, go for it.
If HS is technically a dermatological issue, like a localized disease of the skin and hair follicles, how on earth does a low-grade case on the surface completely wreck the deep pelvic musculature?
It's a fair question.
I mean, anatomically speaking, muscle and skin are entirely different layers, right? They serve completely different functions.
They do, but the flaw in that logic, which is honestly a flaw a lot of medical systems still struggle with, is assuming the body operates in isolated compartments.
Like the different zip codes we mentioned earlier.
Exactly. The nervous system does not view the skin of the perineum and the underlying pelvic muscles as separate zip codes. They share the same neural pathways.
Oh, interesting. So they're on the same circuit.
Right. So when you have severe chronic pain on the surface of the perineal skin, the nervous system doesn't just quietly inform the brain that the surface layer is irritated.
What does it do instead?
It sends a blaring 5-alarm signal to the central nervous system that the entire pelvic region is under severe attack.
So the nervous system is basically hitting the panic button for the entire neighborhood. not just the one house that's actually on fire.
That's a great way to put it. And the neighborhood's automatic response is to go into full lockdown.
Wow.
Which brings us directly to the concept of muscular guarding.
Right, which we saw a lot in the sources.
Yeah, the clinical sources we pulled from vulvovaginal disorders and pelvic floor physiotherapy, they highlight a very clear, very documented pattern here.
What's the pattern?
Chronic inflammatory conditions of the interstitial skin, whether we are talking about a condition like lichen sclerosis or hidradenitis suppurativa, they cause tissue fragility, scarring, and most importantly, chronic pain.
And the body's most primitive, natural response to pain is to physically protect itself from further harm.
Exactly. In response to that localized surface pain from the HS lesions, patients develop a secondary, deeply hidden issue.
The muscle's reacting.
Yes. The pelvic floor muscles become hypertonic. That means they become chronically overactive and excessively tight.
Okay, I think we need to visualize this for the listener because the pelvic floor isn't just one big muscle.
Right, it's a complex group.
The sources mention specific structures: the pubococcygeus, the puborectalis, and the transverse perineal muscles.
There were a lot of Latin names, but yeah.
Basically, if you picture a sort of biological hammock or maybe a trampoline stretching across the bottom of the pelvis, it's supporting the bladder, the bowel, and the uterus.
Right, it holds everything up.
And these muscles all come together and anchor near the back part of the vestibule, right at the perineum. And because of the surface pain, this entire hammock goes into a state of chronic, rigid tension. It's guarding the area.
Spot on. And when those deep muscles are constantly locked in that tightened state, a really brutal cascade of physiological changes kicks off.
Because they never get a break.
Exactly. A muscle that is constantly contracted is physically squeezing the blood vessels that run through it.
Oh, wow. So it's cutting off its own blood supply.
Pretty much. Blood flow through the pelvic floor drastically decreases. And with less blood flow, you get a significant reduction in oxygen being delivered to the muscle cells.
But the muscles still have to work, right?
Right. They are still working overtime holding that tension, so they have to keep burning energy without enough oxygen.
Which leads to
An anaerobic state, which results in a massive buildup of lactic acid in the tissue.
Here's where it gets really interesting. Because almost everyone has experienced this exact mechanism without even realizing it.
Oh, absolutely.
It's exactly like when you have a terrible toothache. Without even noticing, you might spend 3 straight days clenching your jaw to brace against the pain.
You don't even know you're doing it.
Right. And by day 4, the actual tooth might not even be the main problem anymore. Your deep jaw muscles, your masseters, they are in agonizing, radiating spasms from bracing so hard against the original tooth pain.
Yep. The tension becomes its own problem.
And the pelvic floor is doing the exact same thing to protect the perineum.
It's the exact same reflex. If we connect this to the bigger picture, the most dangerous aspect of this mechanism is that the bracing becomes entirely subconscious.
So you can't just flip a switch and turn it off.
No, the jaw muscles are responding to the toothache, just as the pelvic floor muscles are responding to the HS lesions. The brain basically rewires its baseline. It learns to anticipate pain.
Meaning you couldn't just relax those muscles even if you tried.
The body just won't let you. The insidious part of this neuromuscular loop is that even if the low-grade HS finally goes into remission or, maybe is only lightly active for a few months, that learned bracing loop remains active.
That is so unfair. The skin gets better, but the muscles stay locked.
It is. It creates a secondary, entirely distinct chronic pain condition known clinically as hypertonic pelvic floor muscle dysfunction.
Which older medical literature used to refer to as vaginismus.
Correct.
And that secondary pain profile is totally different from the skin pain. The sources describe the lactic acid buildup, triggering sensations of deep burning, throbbing, stabbing, and aching.
It's a completely different type of agony.
Right. So you have the sharp, boil-like tearing pain of the HS on the surface, compounded by this deep, burning, throbbing pain in the muscles right beneath it.
Yeah. We can trace the complete mechanical pathway now. Perineal HS causes localized skin pain and structural damage.
Yeah.
That skin pain triggers subconscious, deep pelvic muscle bracing.
Right.
And then the continuous bracing reduces oxygen and builds up lactic acid, creating deep muscular pain. The systems are just endlessly feeding off each other.
Which brings us to the most intimate and honestly often devastating consequence of this cycle. What happens when a patient in this state attempts physical intimacy?
It's incredibly difficult.
This is really the collision point between muscular bracing and dyspareunia, or painful sex.
So dyspareunia is clinically defined as persistent or recurrent pain with attempted or complete vaginal entry.
And because that biological hammock of the pelvic floor is in a state of hypertonic guarding.
Right, essentially locked down like a fortress to protect the vulnerable, scarred perineal skin.
Then penetration of any kind becomes physically painful, or in many severe cases, completely physically impossible. The muscles simply will not yield.
They won't. And the statistics and the sources are staggering. They really drive the human cost of this home.
Yeah, I was shocked by the numbers.
Studies show that between 51 and 62% of HS patients experience significant sexual dysfunction.
Wow, over half.
Yeah. If you have HS, you are 40% more likely to suffer from sexual dysfunction than the general population.
But as we read further, it becomes pretty clear that it's not just the sheer physical mechanics of the muscles causing this, right?
No, not at all. The psychological factors compound this physical bracing immensely.
Like how so? What's
Yeah.
going on mentally?
The psychological burden of navigating HS is just profound. Patients aren't just dealing with the anticipation of physical pain. They are navigating the anxiety of unpredictable, sometimes really foul-smelling discharge from active lesions.
Which has to be incredibly stressful.
Exactly. They are dealing with severe self-esteem impacts from extensive hypertrophic scarring in highly intimate areas.
Yeah, that changes how you feel about your own body.
Definitely. All of this creates an immense psychological load, and neurologically speaking, anxiety is a threat response.
And the body guards against threats.
Right. When the brain feels anxious or threatened, it signals those pelvic muscles to brace even harder. It basically pours gasoline on the hypertonic fire.
I want to spend a minute on a specific study from Frontiers in Psychiatry that was in our stack, because it contained a detail that is just incredibly heartbreaking, but also really illuminating.
I know exactly the one you mean.
Yeah, they found that despite this profound sexual dysfunction, despite the pain and the bracing and the massive anxiety, HS patients maintain medium to high levels of both dyadic, meaning partnered, and solitary sexual desire.
And that finding highlights the true tragedy of this disconnect.
Right. They still want that connection.
The fundamental desire for intimacy, the biological and emotional drive for human connection, it remains entirely intact. The patient wants to engage.
But they can't.
No, because the body's overzealous protective muscular bracing, tangled up with the psychological distress caused by the skin lesions, creates a literal physical barricade.
So the mind is saying yes, the emotions are saying yes, but the body's autonomic defense mechanisms are screaming no and locking the door.
That's exactly what's happening. And understanding that disconnect is exactly why treating this condition requires us to think critically and collaboratively.
It takes a team.
It really does. Because if a dermatologist only treats the skin, say they prescribe antibiotics or biologics or even perform surgery to remove the tracts.
Right, which sounds helpful.
It is, but they are ignoring the neuromuscular loop that has already been established in the pelvis.
Oh, I see.
The skin might clear up, but the patient will still suffer from painful sex because the pelvic floor is still guarding. It learned the habit.
That is so frustrating.
And conversely, if a physical therapist or a sex therapist only treats the muscular tension or the psychological anxiety, but the active skin lesions are still causing sharp surface pain.
Then the muscles will just immediately go right back into a guarding state to protect the active wound.
Exactly. You can't just treat half the problem.
So what does this all mean? I mean, it means a holistic view of medicine isn't just some nice alternative buzzword. It is an absolute non-negotiable requirement for these patients.
Without a doubt.
A dermatologist treating HS needs to understand pelvic floor mechanics well enough to actually ask the right questions. And a gynecologist or pelvic floor physical therapist treating someone for painful sex, they need to be trained to recognize the signs of hidradenitis suppurativa hiding in the skin folds.
Right. You have to treat the neuromuscular bracing, which usually involves specialized pelvic floor physical therapy, to literally teach the muscles how to release.
And that has to happen alongside rigorous, targeted dermatological care.
The systems cannot be isolated. To actually break the cycle and restore a patient's quality of life, the skin, the muscle, and the psychological impact must all be treated simultaneously.
Which brings us back to the core mission we set for this deep dive.
Yeah.
We asked, can chronic, low-grade HS in the perineal folds cause indirect deep muscular bracing and painful sex?
And based on the clinical evidence, the anatomy, and the psychological data we've walked through, The answer is a resounding, undeniable yes.
It really is. The body's protective guarding mechanisms create a direct mechanical link between surface pain and deep muscle hypertonicity.
It serves as a textbook, albeit devastating, example of how a localized dermatological issue can completely spiral into a regional multi-system dysfunction if we aren't looking at the whole picture.
And the reason we are spending so much time unpacking this is because the real-world implications are massive.
Absolutely massive.
If you or someone you know is suffering from unexplained painful sex, the culprit might be hiding in plain sight. It might be a seemingly unrelated skin condition that has just been dismissed or misdiagnosed as recurrent ingrown hairs or friction boils for years.
And sadly, that misdiagnosis is incredibly common. The clinical data shows the average delay in receiving an accurate HS diagnosis is between 7 and 10 years.
Wow, 10 years.
Yes, that is a decade of chronic, unmanaged pain. That is an entire decade of the pelvic floor learning to brace, guard, and lock down.
That is so tragic. But before we wrap up today, I really want to hand it over to you to talk about one more layer to this that we uncovered in the research.
Wow, this is a fascinating part.
Yeah, because we know the body and mind are connected, but the sources point to a specific biological loop involving stress that takes this whole mechanism to another level.
It's a mind-bending piece of physiology, and it's something for everyone to really mull over.
Lay it on us.
Okay, so based on the dermatological and psychiatric research, we know that psychological stress activates the HPA axis, which is the hypothalamic pituitary adrenal axis.
Right.
When you experience severe stress or anxiety, that axis kicks into gear and spikes your cortisol level.
The stress hormone.
Exactly. High cortisol then triggers something called mast cell degranulation.
Just to keep us grounded here, mast cells are basically the immune system's allergy and inflammation cells, right?
Yep.
And degranulation means they are basically exploding and releasing all their inflammatory chemicals right into the tissue.
Exactly. They act like microscopic landmines.
Oh, wow.
When stress triggers them to explode, they flood the body with inflammatory chemicals. And we know from the clinical data that this specific inflammatory spike can actually cause a fresh HS flare-up.
Wait, really? Just the stress alone?
Yes. So think about the implications for someone trapped in the cycle of dyspareunia. If the fear and anxiety of experiencing painful sex causes severe psychological stress before intimacy even begins, could that anticipatory anxiety be biologically triggering a fresh HS breakout in real time?
That is crazy to think about.
Is the very fear of the pain causing the mast cells to degranulate, thereby physically manifesting the skin disease that causes the pain in the first place?
It's an incredibly sobering thought. The mind-body connection isn't just some abstract woo-woo concept. It is observable biochemistry.
It's literally happening at a cellular level.
Anticipating the pain of the muscular bracing could literally be fueling the inflammation of the skin, creating a perfectly closed-loop system of distress.
It's a tough cycle to break.
It really is. We started this conversation talking about the expectation of clear, visible boundaries in medicine. The idea that the skin is the skin and the muscles are the muscles.
And we proved that completely wrong.
Pretty much. As we've seen today, the boundary between a lesion on the surface of the armpit or groin and a spasm deep in the pelvic floor is a total illusion.
The body's always communicating with itself.
Even when it's speaking a language of pain, we are only just beginning to translate. Keep asking questions, keep looking beneath the surface, and we will see you on the next deep dive.